So Assalamualaikum, good afternoon. My presentation is about the risk factors for severity in children with coronavirus disease 2019. This is a comprehensive literature review from Pediatric Clinics North America done on July 30, 2020. For the introduction, so until recently, 6 different coronaviruses have been identified in humans. Endemic HCoV 0C43 and HCoV 229E were described in the 1960s, while on 2004 and 2005, HCoV NL63 and HCoV HKU1 were identified. The first serious coronavirus disease outbreak occurred in China in 2002 when the novel SARS-CoV emerged, which was thought to have been transmitted by civet cats or bats to humans. Then in 2012, the second novel corona emerged in Saudi Arabia, the MERS-CoV, which is transmitted from camels to humans. These two coronavirus diseases did not affect children widely because of the short-term nature of the epidemic of the SARS and the rigid transmission route for the MERS. Then in 2019 of December, the SARS-CoV-2 has been recognized as the cause of a severe pneumonia and potential damage to vital organs in humans. The first cases were originated in Wuhan in the Hubei province of China, and it subsequently spread to other countries throughout the world. And in February 2020, the WHO designated the disease as COVID-19. So this article analyzes the current knowledge on the risk factors for the progression and severity of COVID-19 in infants and in children. For the methods, original research studies that was published in English between February 26, 2020 and June 10, 2020 were identified using PubMed and Scopus. The initial search yielded 293 articles, of which after screening their titles, 72 were considered relevant to the aim of this review. Pediatric case reports of COVID-19 were included only if they provided information about the risk factors for severe disease. So a total of 23 studies were eventually selected, and most of these studies originated in China, in the US, Italy, Spain, and South Korea. For the epidemiology, COVID-19 worldwide is less common in children and in adults. A review of 72,314 cases by the Chinese CDC showed that less than 1% of the cases were in children younger than 10 years, and 1% of cases were in children aged 10 to 19 years. In the US, among the 149,882 reported cases of COVID-19, 1.7 were in children less than 18 years. From the current available data, it seems that children tend to have asymptomatic or mild disease more commonly than adults. But severe cases, severe and critical cases, and even deaths have been reported worldwide in younger patients less than 18 years. Study of 32,583 confirmed cases of COVID-19 from Wuhan, China. 4.1% of severe and critical cases were in patient age less than 20 years. So risk factors for severity in corona disease 2019. So the impact of age, a series of 2,135 children with suspected and confirmed COVID-19 cases from China. Severe and critical cases were reported in 10.6% in less than 1 year of age, and 7.3% of those aged 1 to 5 years. 4.1 of those aged 6 to 10 years, and 3% of the children aged greater than 16. In this study, one 14-year-old boy died, but they did not. There was no information regarding if that patient had any underlying comorbidities or other risk factors. And in this, out of these 2,135, only 728 had laboratory confirmations of COVID. And the severe symptoms in the suspected cases, these could have been caused by other pathogens other than the SARS-CoV-2. Also in the same country in China, they reported 55-day-old female infants and a 3-year-old infant with no apparent risk factors other than the young age. But also there are cases that has been reported of infants in China and also in Vietnam that despite their young age, they had only mild diseases. And there is a study done with 10 diagnosed COVID-19 who were otherwise healthy with mild or no symptoms, and they were less than 1 year of age. A study in the US from the Children's National Hospital in Washington, D.C., 177 children, they noted that the adolescents and the young adults were more commonly critically ill than the young children. Another study in the US reported that the mean age of positive children was significantly higher than those who are testing negative. And in this study, they noted that aside from the older age in children, they noted that these children were of African American. So the race also were, they noted that it is significantly higher in those African American children. A study done in the UK with 58 children, also aside from the older age group in children, they noted that race was described as a risk factor for COVID-19. The impact of male gender. So male gender is a risk factor for COVID diseases in adults. But a study among 2,143 children with COVID-19 in the study of Dong and colleagues in China, no significant difference was reported in the number of cases between the boys and the girls. And also there was no detailed information that was given on the gender of the severe cases, severe and critical cases. In a study done in the ICUs of in US and Canada, they noted that 52% were boys. So severe disease has also been reported in girls, and current data suggests that in children, male gender is not an independent risk factor of severe COVID-19. For the underlying medical comorbidity, in a series of 171 children with COVID-19 from China, they described 3 patients requiring ICU support and invasive mechanical ventilation, and all had an underlying comorbidity. One was a 10-month-old male infant with intussusception who developed a multi-organ failure and died after 4 weeks of admission. The second one had a leukemia on maintenance chemotherapy. And the third was age 13 months with bilateral hydronephrosis and calculus of the left kidney. But also in this study, they did not mention about the 168 children who did not need ICU admission if there was an underlying condition. There was a study in Italy, the Confidence study, which included 100 children. 27% had an underlying medical condition. 9 of these children needed respiratory support, and 5 were aged less than 1 year, and 6 had an underlying condition. Those that had critical and severe cases were both in children with underlying medical condition. And another study, this is in China, which involves 25 pediatric cases of COVID-19. 2 1-year-old boy needed invasive mechanical ventilation, and these 2 boys had a history of congenital heart disease. One of them also had malnutrition, and the other one had a co-infection with Enterobacter aerogenes. But in the study done in the US, this is one of the studies that was first done in the US. It involves 2,572 pediatric cases, and 20% of these were hospitalized. And among these it is reported to be in younger age, less than 1 year. An underlying medical condition was noted in 77% of those hospitalized children. And the most common comorbidities were chronic lung disease. They included asthma, cardiovascular disease, and immune suppression. 3 deaths were reported, but it is still not clear if it is because of COVID. It is still under investigation. Another study in the US that involves 48 children admitted to ICU, 83% had significant pre-existing comorbidity. But also we have to take note that severe and critical cases has also been reported in children with no underlying comorbidity. There is a study also done in China, which involves 8 severe and critical cases in children in Wuhan. 7 of these patients had no comorbidities. They were previously healthy. And the age range of the patients in these 8 severe cases was from 2 months to 15 years. 6 were boys, and only 1 of them had underlying medical condition, and it was leukemia. An information from a registry of 310 hospitals in Madrid, Spain, showed that 41 children with COVID-19, 60% were hospitalized, and 4 of these were admitted to ICU needing respiratory support. And of these children, only 1 had a previous condition, which was recurrent wheezing. And in these children, no patient died. A recent report also from Paris, France, of 27 patients with severe COVID-19, 70% had an underlying medical condition. 5 of these children died, but of these 5, 3 had no underlying comorbidity. So it is suggesting that comorbidities may be a risk factor for severe disease and fatality, but other mechanisms may also be implicated in the severity of the disease. So comorbidity is not the only risk factor for progression of the disease and development of complications. Co-infection with another pathogen. There has been one report from China, the one I discussed before, regarding 1 patient with congenital heart disease, and this patient had a co-infection with Enterobacter aerogenes. Also in China, they reported a case of a 2-month-old infant who had co-infection with RSV. Laboratory findings, based on the current available data, it is not possible to document a pattern of laboratory values in pediatric COVID-19 according to the severity of the disease. Laboratory data from 8 severe pediatric cases in China showed normal or increased leukocyte count and high levels of C-reactive protein, procalcitonin, and lactate dehydrogenase. Some of these patients had abnormal liver function tests. And in a study of 67 children in the US, admission to an ICU was associated with higher levels of CRP, procalcitonin, pro-BNP, and an increase in platelet count. This is a study done by Henry et al. They collected, I think, 23 studies with 625 pediatric patients. And in this study, they noted that 69.6% of the children had a normal leukocyte count. And the investigators commented that the absence of the lymphopenia in children may be explained by the having a milder disease. Another assumption is that the increase in procalcitonin level could be caused by a bacterial co-infection as a complication of COVID-19. So risk factors for pediatric inflammatory syndrome associated with severe SARS-CoV. So a syndrome of fever, multisystem inflammatory syndrome, has recently been described in children with COVID-19. And some of these children presented with shock and multi-organ failure, and others had characteristic of Kawasaki disease or a combination of Kawasaki-like disease and shock. Most of the studies to date have reported that those children having the MIS presents at an older age, unlike the the one having a severe COVID, with a median age of 8 to 10 years. In a retrospective study of 35 children with MIS admitted to the ICU in France and Switzerland, comorbidities were present in 28% of the children. This includes asthma and being overweight. But another studies done in Europe, this is specifically in Italy and the UK, most of the patients were previously healthy. In a study of 8 children from the UK with MIS, 6 were Afro-Caribbean and 5 were male. So it has been suggested that Black and Asian races may be predisposed to this clinical complication. Laboratory findings in children with MIS were characterized by a marked increase in levels of inflammatory markers like CRP and ferritin, and cytokine storm, with specific increase in the level of interleukin-6 and macrophage activation. Also, patients with MIS were noted to have significant increase in the BNP and troponin. So what mechanism play a role in the typical picture of coronavirus disease in children? Why COVID-19 appears to be less common and less severe in children? They said it is unclear, but they had several hypotheses, and 3 are in these slides. So for the environmental epigenetics, the effect of the environment must be considered a factor with significant impact on the infection with COVID-19. So we all know that children have healthier airway tracts because of having less exposure to cigarette smoke, air pollution, chemicals, industrial pollutants than in adults. And in adults, these environmental factors, especially the smoking, it has a negative epigenetic impact on epithelial and immune cells that would lead to vulnerability of all respiratory viruses, including the SARS-CoV-2. Also, they explained that children who were hospitalized with COVID-19, especially those with severe cases that were admitted in the ICU, they were less than 3 years of age. And this finding may be explained by the immaturity of the immune system in this age group, and also the likelihood of wearing face mask in this, low likelihood of wearing face mask in this age group, and the subsequent high viral load. Another reason also for the different clinical picture of COVID in children than in adults is that in children, there are fewer underlying disorders that may predispose to severe COVID-19 as compared to adults. And those children who had severe COVID-19 in children, they were noted to have pre-existing conditions like asthma, malignancies, cardiovascular disorders, and immunosuppression. Entry of the virus into the cell, as we all know that the recent study indicate that the ACE2 is the likely to be the receptor for SARS-CoV-2. And they said that the differences in the distribution, maturation, and functioning of the ACE2 in the developing phase of childhood is a possible reason for milder SARS-CoV-2 infection. So there are different expressions of the ACE2 in the respiratory tract of children and in adults. For the immune antiviral response, so frequent exposure of children to viral infections, it boosts the immune system and passively enhances the response to SARS-CoV-2. The presence of other concurrent viruses in the airway mucosa, it may limit the replication and the viral load of the SARS-CoV-2. So the immune system, it undergoes different changes from birth to adulthood, so especially the lymphocytes. And interaction of the lymphocytes with the SARS-CoV-2 may be different in children than in adults. It is documented that lymphocytopenia is more frequent in adults than in children, and not noted in children, I mean. Another immunologic aspect that could be related to mild disease in children is the trained innate immunity because of the routine use of various vaccines, including the BCG. Also, they mentioned about several studies that identified the link between inadequate vitamin D concentrations and the development of upper and lower respiratory tract infections in infants and in young children. So to summarize, Although children are less susceptible to COVID-19, the clinical picture in childhood is often distinct from that in adults, though both of the age group chronic underlying medical problem can predispose to severe disease. But in contrast to adults, where older age is an independent risk factor for severity and mortality, in children, very young age is considered a risk factor for severity. But this has recently been questioned. And also the MIS in children occurs in older children. A distinct pattern of laboratory findings has not emerged as being associated with severity of the disease in pediatric cases of COVID-19. Increased levels of the inflammatory markers like procalcitonin and CRP could be caused by a bacterial co-infection as a complication of COVID-19. So several aspects could be implicated in the severity of COVID-19 in children, such as co-infection with RSV, responsiveness of the immune system, vaccination history, level of vitamin D, and genetic polymorphism. But due to the present insufficient data, this limits the ability to draw such conclusion. So it is important to further study the potential risk factors for severe disease in children and to clarify the underlying mechanisms in order to improve the management of children with COVID-19. Thank you. Any questions?